Heart failure is a syndrome that develops when the heart can no longer pump enough blood to meet the body's oxygen and nutrient needs. This is not an acute single event, but rather a progressive condition that worsens over time. The older term for this condition is congestive heart failure, or CHF. However, that term is used less now because congestion is not always present. Some patients may not have fluid buildup, but the underlying problem, an inability of the heart to pump effectively, is still there. The key takeaway is that heart failure is about the heart's reduced pumping ability, which leads to a cascade of problems: fatigue, fluid retention, shortness of breath, and reduced quality of life. Left-sided heart failure happens when the left ventricle cannot pump blood effectively into the aorta and systemic circulation. A key factor here is afterload. This is the amount of force the left ventricle must generate to push blood through the aortic valve into the aorta. Peripheral vascular resistance, or the pressure within the arteries, directly influences afterload. Hypertension is the most common cause of left-sided heart failure because chronic high pressure makes the heart work harder, eventually weakening the left ventricle. When the left ventricle fails, blood backs up into the lungs, since it cannot move forward efficiently into the systemic circulation. This leads to pulmonary congestion and alveolar edema, which cause hallmark symptoms like shortness of breath, crackles, cough, and orthopnea. Right-sided heart failure often develops as a consequence of left-sided heart failure. When the left side of the heart fails, pressure builds in the pulmonary circulation, and the right ventricle must continually pump blood against this increased resistance. Over time, the right side weakens and fails. Another cause is cor pulmonale, which is failure of the right ventricle due to chronic lung disease and pulmonary hypertension. In this case, the right ventricle becomes enlarged and thickened, but eventually can't keep up with the high pressures in the pulmonary arteries. When the right ventricle fails, blood backs up into the systemic circulation instead of the lungs. This leads to peripheral edema, swelling in the legs, ankles, and sometimes the abdomen, ascites. Patients may also develop jugular venous distension. The key takeaway is that right-sided heart failure causes systemic fluid retention, while left-sided heart failure causes pulmonary congestion. Recognizing where the blood backs up helps differentiate the two conditions. Acute heart failure is a medical emergency. It happens when there is sudden severe fluid congestion in the alveoli of the lungs. This is sometimes described as the patient drowning in their own secretions. It is life-threatening and requires immediate recognition and intervention. The classic sign is pink frothy sputum, which results from fluid mixing with air in the lungs. Other signs and symptoms include rapid respirations with use of accessory muscles, severe shortness of breath, dyspnea, and orthopnea, meaning the patient cannot breathe while lying flat, crackles and wheezes heard on lung auscultation, anxiety and restlessness because the patient is hypoxic and struggling to breathe, cool, clammy skin reflecting poor circulation and sympathetic nervous system activation. Chronic heart failure is a progressive condition. Unlike acute heart failure, which is sudden and life-threatening, chronic heart failure develops over time, and the signs and symptoms may gradually worsen as the disease advances. Patients often present with fatigue and weakness since the heart cannot supply enough oxygen-rich blood to the body. Exertional dyspnea is common. Patients become short of breath with even mild activity. Some develop orthopnea or paroxysmal nocturnal dyspnea, where they wake up gasping for air. Other symptoms include cough, crackles, and wheezes from fluid congestion in the lungs. The heart may try to compensate by beating faster, leading to tachycardia. Chest pain can occur if there is underlying coronary artery disease. Systemic effects also appear. Patients may show Cheney-Stokes respirations, peripheral edema, anemia, and nocturia as the kidneys are affected. Cyanosis, altered mental status, and even malnutrition may develop as the body's organs and tissues are deprived of adequate oxygen and nutrients. The key takeaway is that chronic heart failure is long-term, progressive, and systemic. It affects not only the heart and lungs, but also the kidneys, brain, and overall nutritional status. Nurses must monitor symptoms closely to prevent decompensation into acute heart failure. When treating chronic heart failure, the main goal is to improve the pumping ability of the heart while decreasing its oxygen demands. Every intervention is designed to either strengthen the heart or reduce the strain placed on it. The first step is to identify and correct the underlying cause. For example, if heart failure is due to hypertension, controlling blood pressure is critical. If it is due to coronary artery disease, revascularization may be needed. Next, we work to increase the strength of the heart's contraction. Medications like digoxin, ACE inhibitors, and beta blockers can help the heart pump more efficiently. It is also essential to maintain an optimum water and sodium balance. Too much sodium or fluid worsens fluid retention, leading to congestion and edema. That's why diuretics and sodium-restricted diets are often prescribed. Finally, the heart's workload must be decreased. This can be achieved with medications that lower blood pressure, reduce afterload, or slow the heart rate, allowing the ventricles more time to fill and eject blood effectively. Medication therapy is the cornerstone of chronic heart failure management. The goal is to reduce symptoms, improve quality of life, and slow disease progression. We start with oxygen therapy when patients are hypoxic to support oxygen delivery to tissues. Next, ACE inhibitors or angiotensin II receptor blockers, ARBs, are first-line drugs. These relax blood vessels, lower blood pressure, and decrease the heart's workload. In more advanced cases, angiotensin receptor neprilysin inhibitors are used for stage C heart failure, offering additional benefit. Beta blockers help by slowing the heart rate, lowering blood pressure, and giving the heart time to fill and pump more effectively. Diuretics are used to reduce fluid overload, helping relieve congestion, swelling, and shortness of breath. Inotropic agents like digoxin may be used to improve the strength of heart contractions. Vasodilators reduce afterload, making it easier for the heart to eject blood. A newer medication, ivabradine, slows the heart rate in patients with persistent tachycardia, helping reduce oxygen demand. Finally, anticoagulants may be prescribed if the patient is at risk for clot formation, especially if atrial fibrillation is present. The intra-aortic balloon pump, or IABP, is a mechanical device used to support patients with severe heart failure or cardiogenic shock. It is inserted into the aorta through a catheter, usually placed via the femoral artery. The balloon inflates and deflates in synchronization with the cardiac cycle. During diastole, the balloon inflates. This increases blood flow to the coronary arteries, improving oxygen supply to the heart muscle. During systole, the balloon deflates. This reduces afterload, making it easier for the left ventricle to pump blood forward into the aorta. The end result is increased myocardial oxygen delivery and decreased cardiac workload, which helps stabilize critically ill patients while other treatments are initiated. The key takeaway is that the IABP is a temporary support device. It doesn't cure heart failure, but buys time until the heart recovers, or more definitive therapies like surgery or advanced devices can be used. Ventricular assist devices, or VADs, are mechanical pumps that support the failing heart. They help the ventricles pump blood more effectively, reducing the symptoms of heart failure and improving circulation to the body. VADs can be used as a bridge to transplantation, meaning they keep patients stable while waiting for a donor heart. They can also be used as destination therapy, which means they serve as long-term treatment for patients who are not candidates for a transplant. In some cases, VADs are part of heart replacement therapy, working alongside or in place of the natural heart when it can no longer meet the body's demands. On the diagram, you can see how blood flows from the left ventricle into the LVAD pump, and then it is pumped into the aorta. The device is powered by an external battery and control unit, which the patient carries outside of the body. The key takeaway is that VADs and artificial hearts are life-saving technologies that either buy time until transplant or serve as permanent support for patients with severe end-stage heart failure. Cardiac transplantation is considered the treatment of choice for patients with end-stage heart failure who no longer respond to medications or mechanical support devices. Because it is such a complex and limited resource procedure, patients must meet strict selection criteria to be considered. Before the transplant, patients receive immunosuppressive therapy to prepare the body and decrease the risk of rejecting the new heart. After transplantation, this therapy continues lifelong to prevent rejection of the donor heart. However, this also increases the risk of infection and requires careful, ongoing medical management. The images here show the surgical process, removing the failing heart and implanting the donor heart in its place, connecting the major blood vessels and restoring circulation. The key takeaway is that cardiac transplantation is life-saving, but comes with lifelong challenges: strict follow-up, adherence to anti-rejection medications, and balancing the risk of infection with the need to suppress the immune system. After cardiac surgery, patients require close monitoring and nursing care to prevent complications and promote recovery. Several common nursing diagnoses guide our care. The first is acute pain, which results from the sternotomy incision, chest tubes, and invasive lines. Effective pain management is essential for healing and for helping the patient participate in activities such as coughing, deep breathing, and early ambulation. Next is ineffective airway clearance and impaired gas exchange. Because of anesthesia, immobility, and pain, patients are at risk for shallow breathing and difficulty clearing secretions. Nurses must monitor respiratory status, encourage incentive spirometry, and support coughing and deep breathing. We also watch for risk for infection. The surgical incision, invasive lines, and immunosuppressive therapy all increase this risk, so strict aseptic technique and frequent assessment are critical. Finally, deficient knowledge is an important diagnosis. Patients and families often feel overwhelmed by the complexity of care. Nurses play a key role in teaching about wound care, medications, infection signs, and lifestyle adjustments that will support recovery and long-term health. The takeaway is that post-operative cardiac surgery care requires a holistic approach, managing pain, supporting breathing, preventing infection, and educating patients for self-care. Correct answer 1. Correct answer 4. Correct answer 2. Correct answer 1, 2, 4. Correct answer 1, 2, 3.